Childbed fever killed somewhere between 10 and 35% of women who gave birth in European hospitals during the 18th and early 19th centuries. In some facilities, during some outbreaks, it was closer to half. And for most of that period, the medical community's response was essentially a shrug. Not a cruel shrug, not a lazy one, a genuinely sincere shrug rooted in how doctors at the time understood disease. Illness was caused by miasma, bad air, constitutional weakness, divine will, or some poorly understood interaction between a vulnerable postpartum body and the general atmosphere of a hospital. Under that framework, childbed fever, puerperal fever, technically, wasn't a solvable problem. It was a tragic but inherent feature of childbirth in institutional settings. You could maybe improve ventilation, you could pray, you could adjust diet. But you couldn't crack it open and fix it, because there was nothing to fix. It just happened. This framing matters enormously, because it explains why what came next didn't look like a triumph. It looked like an attack. Vienna General Hospital in the 1840s was one of the largest and most prestigious teaching hospitals in Europe. It was also, from a certain angle, running a natural experiment that nobody had thought to examine carefully. The maternity ward was divided into two clinics, the first division and the second division, operating in adjacent sections of the same building, delivering babies under similar conditions, drawing from the same population of patients. The first division was staffed by medical students and physicians, who also performed autopsies as part of their training. The second division was staffed by midwives, who did not. The mortality rates were not slightly different. They were grotesquely, inexplicably different. Ignaz Semmelweis, a Hungarian-born physician working in Vienna, began compiling records systematically starting around 1844. In the first division, the annual mortality rate from puerperal fever routinely ran between 10 and 15%, and in some months spiked higher. In the second division, the rate hovered around 2 to 4%. Women admitted to the first division knew something was wrong, some begged on their knees not to be assigned there, preferred to give birth in the street and be admitted afterward, because admission to the street was classified differently and got you into the second division's numbers. The gap was not a rumor or a feeling. It was documented, year over year, in the hospital's own records. Semmelweis didn't invent this data. He just looked at it with the specific, itchy focus of someone who couldn't accept that it didn't mean something. The question was what? Semmelweis worked through hypotheses methodically. Overcrowding. Both wards were crowded. Ventilation. Roughly equivalent. The manner of delivery, the first division used a different position from the second, he actually tested by changing the protocol, and it made no difference. Priests walking through the ward with last rites, which required passing through the first division. He rerouted the priest. Still no meaningful change. He was stuck, and then in early 1847, his friend and colleague Jacob Kolečka died. Kolečka was a professor of forensic medicine. During a teaching autopsy, a student's scalpel slipped and nicked Kolečka's finger, a small wound, the kind that happened. Kolečka developed a systemic illness and died, and when Semmelweis read the autopsy report, he stopped. The pathological findings were essentially identical to what he saw in women who died of puerperal fever, the same lesions, the same tissue damage, the same pattern of systemic infection spreading from a localized origin. Semmelweis made a leap. It wasn't a leap into nowhere, it was a leap with real structural logic underneath it. If Kolečka died from cadaverous particles introduced through a wound during autopsy, and medical students were going directly from performing autopsies to examining laboring women without washing their hands in any meaningful way, then those same particles could be transferred to the women. The midwives in the second division didn't perform autopsies. They never handled cadavers. Their hands were, in whatever sense mattered, clean. Germ theory did not exist. Semmelweis had no concept of bacteria, no understanding of infection at a microbial level, no mechanism he could name precisely. He used the term cadaverous particles because that was as specific as the available conceptual vocabulary allowed. What he had was a pattern, a parallel, and a proposed intervention he could test immediately. In May 1847, he instituted mandatory handwashing with chlorinated lime solution, not soap and water, which he'd already determined wasn't sufficient, but chlorinated lime, which we now understand as a disinfectant capable of denaturing proteins and disrupting microbial cell walls. He required everyone entering the maternity ward from the autopsy room to wash. The results were not subtle. In the month before the intervention, the First Division's mortality rate was around 10%. Within 2 months of mandatory washing, it dropped below 2%. By some months in 1848, it was below 1%, lower, in some periods, than the Second Division had ever achieved. Semmelweis tracked this obsessively, month by month, and he extended the protocol as he identified other potential sources of cadaverous contamination, including patients with existing infections. Each time he tightened the protocol, the numbers responded. This was not a one-time fluke. Over years of documentation, the intervention held. And the medical establishment largely rejected it anyway. Understanding why requires letting go of the satisfying narrative where smart person proves obvious truth and idiots refuse to believe it. The resistance to Semmelweis was multi-layered and, in some ways, internally coherent given the constraints of the time. The most viscerally important factor, accepting Semmelweis's explanation, meant accepting that physicians, the most educated, most prestigious actors in the medical system, had been killing their patients. Not negligently, not maliciously, but systematically, by going from the dead to the living without adequate cleaning. This was not just professionally embarrassing. Within the moral framework of the time, it was almost theologically intolerable. Doctors saw themselves as healers by vocation. Charles Meigs, a prominent Philadelphia obstetrician who would later attack similar conclusions on the American side, reportedly said that a gentleman's hands could not be a source of disease. That line is often quoted mockingly, but it reflects something real. The status system of medicine was intertwined with the theory of disease transmission in a way that made the new theory feel like a personal accusation. Then there was the theoretical void. Semmelweis couldn't tell anyone why handwashing worked in terms that connected to any accepted scientific framework. Cadaverous particles was not a mechanism. It was an observation dressed as an explanation. Without germ theory, there was no underlying model into which his findings fit, and in the absence of that model, skepticism was not entirely unreasonable, annoying and costly, but not entirely unreasonable. Evidence without an explanatory framework travels very poorly. It always has. Semmelweis's own personality didn't help, though it's important not to overweight this factor. He was combative. His 1861 book summarizing his work was long, repetitive, and difficult to read. His open letters to prominent obstetricians in the early 1860s escalated into personal attacks on individuals he accused of being murderers. Karl Braun, who succeeded Semmelweis as mentor at Vienna General and became one of his most effective opponents, found ways to attribute the ward's improved mortality to other causes in official publications: crowding changes, ventilation improvements, anything but the handwashing. Braun had institutional power and used it. What makes the Semmelweis story something other than a lone genius narrative is that he wasn't alone. Oliver Wendell Holmes Sr., yes, the poet and essayist, who was also a physician and Harvard Medical School dean, published a paper in 1843, before Semmelweis had even begun his systematic work, arguing that puerperal fever was contagious and transmitted by physicians and nurses who had contact with infected patients or cadavers. Holmes's argument was grounded in case analysis rather than controlled statistics, but the conclusion was essentially the same. And Holmes faced the same furious backlash from Meigs and others, the same accusations of professional slander, the same dismissal from the mainstream. Two men, different countries, different methodologies, same conclusion, same wall. This is not a story about one difficult personality encountering one unlucky set of circumstances. It's a story about how an entire professional system processes ideas that implicate the system itself. Semmelweis deteriorated through the early 1860s. The obsessive letters, the apparent erratic behavior, historians still debate how much of this represented organic mental illness, how much was professional despair compounding into crisis, and how much was behavior that looked extreme by the standards of the time but might be understood differently today. In 1865, he was committed to a mental asylum in Vienna. He was 47. He died there within 2 weeks of admission, of a systemic infection, the pathological findings looking, according to some accounts, remarkably like those of puerperal fever. Whether this resulted from a wound sustained during or after a physical struggle with staph, or from some other cause, remains disputed. The irony is almost too structured to be real. He likely died of the class of infection he had spent 20 years trying to prevent. The vindication, when it came quickly. Louis Pasteur's germ theory work through the late 1850s and 1860s, and Joseph Lister's development of antiseptic surgical technique in the late 1860s, suddenly gave medicine the explanatory framework that Semmelweis had been missing. Cadaverous particles had a name now. They were microorganisms. They could be killed. The mechanism existed. And once the mechanism existed, handwashing wasn't a strange empirical claim without a home, it was an obvious logical consequence of a theory that was rapidly becoming mainstream. Adoption of antiseptic principles moved quickly. The thing that had seemed like mysticism became common sense almost overnight. That's the real lesson, and it's an uncomfortable one. Semmelweis wasn't rejected because the evidence was weak, the evidence was extraordinary. He was rejected because evidence without a working theoretical framework to carry it doesn't move through institutions the way we'd like to think it does. The data doesn't speak for itself. It speaks through models, through consensus, through the explanatory stories a field has already agreed to find plausible. Strip those away and even the clearest signal becomes noise. That dynamic didn't end with Semmelweis. It's not a 19th century problem. It's how science, as a human social institution, actually processes anomaly, an understanding that is considerably more useful than simply celebrating the visionary who was right before everyone else caught up.